Hello, my name is Andrea Boccardi Vidarte. I have been a senior advisor at UNH for 17 years and since 2017 been leading the Stigma and Discrimination portfolio in the Human Rights and Gender team. I wish that at the time of this session, all participants, organizers of this virtual conference, and their respective families are healthy and safe in these difficult times of the COVID-19 epidemic. I would like to thank for the invitation and opportunity to present available evidence UNAIDS has collected on how lessons learned and best practices of addressing HIV-related stigma and discrimination can apply during national responses to COVID-19 epidemic. The title of the presentation is COVID-19 Leveraging Best Practices and Lessons Learned from HIV Stigma and Discrimination Mitigation. Allow me to walk you through the content of this presentation. Today, I will provide information available from reports of stigma and discrimination during the early stages of the COVID-19 response and its interface with the HIV epidemic. Review possible impact of the COVID-19 epidemic on the fast-track response based on modeling. Share lessons learned and best practices taken by governments during early responses to the COVID-19 epidemic. Unpack evidence-based interventions recommended to eliminate stigma and discrimination in 6 settings during early COVID-19 responses, and to introduce the Global Partnership for Action on Stigma and Discrimination. Let me start quoting the 2020 UNAIDS Global AIDS Update Report, Seizing the Moment, Tackling Entrenched Inequalities to End Epidemics. A deadly virus jumps the species barrier and quietly spreads. Little is done at first. Denial, discrimination, and discord undermine an effective response. The poor, marginalized, are the most exposed to infection and death, and the least able to cope with the broader impacts of the disease. Resentment and frustration build. Emotions boil over. Protesters march. When HIV emerged as a global pandemic, change took years. When the calls from activists and the coffins of the dead could not longer be ignored, consensus was achieved and global commitments were made. Public health actions that once seemed impossible are now commonplace. An unprecedented global health crisis requires an unprecedented approach. For COVID-19, the time for debate and change has been compressed from years to weeks. COVID-19 has provoked a series of discriminatory acts across continents with different groups as targets. 10 UNESCO chairs dealing with human rights and social inclusion provided insights as to how this global phenomenon is manifesting itself in their countries. The information is not exhaustive, and its main purpose is to help illustrate through local experiences the plurality of forms that discrimination and stigma related to COVID-19 may take in different contexts. Since the COVID-19 outbreak, the instability and fear that the pandemic engenders is exacerbating existing human rights concerns, such as discrimination against certain groups, contemporary forms of racism, and COVID-19 related attacks against minority groups worldwide. Despite the scarcity of data on this phenomenon, the discriminatory incidents reported in newspaper articles and on social media seem to confirm that this is a global phenomenon. While the profile of victims varies from country to country, there seems to be a common pattern in discriminatory acts occurring during the pandemic. The target is generally the other, the foreigner, someone belonging to an ethnic or cultural minority, etc. During the first phase of the COVID-19 contagion, those who suffered the most from discrimination were Asians and people of Asian descent who were frequently targeted for causing the pandemic and its spread. As reported by UNESCO chairs from Europe, discriminatory episodes consisted of verbal assaults in public places, denigrating campaigns on social media, and boycott of their businesses' activities, and in some cases, difficulties in access to educational institutions. Discriminatory attacks spilled over to other groups. Roma communities in northern Spain were targeted, and because being considered to be the first to be contaminated by COVID-19. UNESCO chairs in India reported that Muslim communities, who represent the largest minority of the country, have been victims of attack and other forms of discrimination. Targets of discriminatory attacks changed over the weeks as another type of stigmatization arose out of the fear of being infected. In some cases, this fear resulted in threats against healthcare workers and supermarket clerks who were at risk of being infected in their workplaces. As the pandemic escalated, international and regional organizations called on states for solidarity, not only in tackling the health emergency, but also its impacts, especially on the most vulnerable. In many countries, responses took the form of mass media campaigns launched by national and local authorities and civil society. The main objective was to call for citizen solidarity and to contribute to changing people's attitudes towards groups who are at risk of discrimination in a specific context. The UN Secretary General called all agencies in the early stages of the COVID-19 pandemic to support the efforts of the World Health Organization in their own respective areas of expertise. In order to fulfill this obligation, UNAIDS launched a report on August 27th titled Rights in a Pandemic, Lockdowns, Rights, and Lessons Learned in the Early Response to COVID-19. This report draws particular attention to public health orders that restricted people movement and have impacted human rights during the period of February to mid-May 2020. The report focused on people living with and most affected by HIV, including key populations, sex workers, people who use drugs, gay men and other men who have sex with men, transgender people and prisoners, and women and girls. Given the urgency of the situation, it was not possible to undertake a global review. Policies and practices were reviewed only in 16 countries, in 2 of the regions that contain countries with some of the highest prevalence of HIV in the world, Sub-Saharan Africa and Latin America and the Caribbean. But these should be seen as examples of a much broader global phenomenon. The countries selected were Argentina, Botswana, Brazil, Cameroon, Central African Republic, Chile, Colombia, El Salvador, Ethiopia, Jamaica, Kenya, Malawi, Nigeria, Peru, South Africa, and Uganda. It is critical to note, however, that lockdowns and human rights concerns related to them are present in countries in all regions, including in Asia and the Pacific and in Europe. Since then, many countries mentioned in this report have made changes and adapted. Lessons have been learned across the world, and some problems have been solved. While reviewing information gathered for the report, particularly on the impact of people who are living with or vulnerable to HIV, 10 key areas of human rights concern emerge that are applicable both to communities of people who are living with and vulnerable to HIV and to the broader general population. These areas are the following: a disproportionate, discriminatory, excessive use of criminal law, discriminatory enforcement against key populations, state violence, disproportionate response of actions by law enforcement and security force when enforcing COVID-19 responses measures, legal restrictions of movement that prevent access to food, healthcare, shelter, or other basic needs, limitation of movements which were non-specific, not time-bound, and not evidence-based. Disruptions in HIV treatment and prevention, with more aggressive policy shifts to harm reduction services. Overcrowding in detention settings and limited access to health and sanitation for people deprived of liberty. Gender-based violence against women, children, and lesbian, gay, bisexual, transgender, and intersex people during lockdowns. Arrest and harassment against community health workers and community-led service providers, journalists, and lawyers, which are essential workers to ensure the protection of key populations and other vulnerable groups. And finally, shrinking space for independent civil society and judicial accountability. Many governments at the national and subnational levels are taking actions to affirm human rights protections and empower communities. For example, some governments are extending access to water, providing social protection, adapting health service delivery, providing emergency food supplies, instructing police to hand out masks, and supporting community health workers to reach those likely to be left behind. The COVID-19 pandemic is one of the gravest threats facing society today. Within a short period of time, it has reached every corner of the globe and it has touched every aspect of our lives. The socioeconomic impacts of this pandemic will be deep and long-lasting. At the same time, the HIV pandemic is not over. With 1.7 million new infections in 2019 and 38 million people living with HIV worldwide, we are living in a time of two parallel pandemics. As countries around the world respond to the COVID-19 pandemic, it is critical that the response is firmly grounded in respect for human rights. The HIV epidemic taught the world that rights-based responses are more effective in the long run for engaging, educating, and empowering communities to protect their own health and for spreading awareness and accurate information. Rights violations can undermine trust and compliance with public health directives, economic resilience, and ultimately the success of public health efforts over time. Although there are clear differences between COVID-19 and HIV, these principles continue to be relevant as governments seek to secure the public's consistent participation with public health advice over many months while the world waits for an effective vaccine. Which was the situation of the HIV response when COVID-19 pandemic surged? Our progress towards ending AIDS as a public health threat by 2030 was already off track before the COVID-19 outbreak, as you can see in these graphs. Of the 38 million people living with HIV, 25.4 million people are now on treatment. That's a great achievement. Increased access to antiretroviral therapy has averted an estimated 12.1 million AIDS-related deaths since 2010. But 12.6 million people are still waiting for treatment. Now, new HIV infections have been reduced by 23% since 2010, thanks in large part to a substantial decrease of 38% in Eastern and Southern Africa. But HIV infections have increased by 72% in Eastern Europe and Central Asia, by 22% in the Middle East and North Africa, and by 21% in Latin America. Look at the modeling in this graph. It's the green break line. As you can see, responses in countries and regions show the global HIV response fall further behind on its 2020 commitments. People living with HIV and people at higher risk of HIV infection are facing life-threatening disruption to health and HIV services as COVID-19 cases overwhelms health system capacities and lockdowns limit movement and strain economies. Voluntary male circumcision, condom production and distribution, pre-exposure prophylaxis, HIV testing and treatment, and other programs have all been negatively affected. Recent modeling, as you can see in this graph, has estimated that a 6-month disruption of antiretroviral therapy could lead to more than 500,000 additional deaths from AIDS-related illness in sub-Saharan Africa in 2020-2021. For instance, if the COVID-19 pandemic interrupts antiretroviral therapy for 20% of people living with HIV for 6 months, it would result in more than 110,000 additional AIDS-related deaths. If services to prevent mother-to-child transmission were similarly halted for 6 months, the estimated increases in new child infections would more than double in Malawi, Uganda, and Zimbabwe, and increased by 83% in Mozambique. In the early stages of the COVID-19 epidemic, UNAIDS consulted with the HIV and Human Rights Reference Group, experts from civil society, academia, and public health and other United Nations agencies to identify key learnings from the HIV response that are critical in ensuring an evidence-informed and effective response to an epidemic. Recommendations were published in a report called Right in the Time of COVID-19, Lessons from HIV for an Effective Community-Led Response. Here are 7 key takeaways of this report. 1. Engage affected community from the beginning in all response measures to build trust, ensure suitability and effectiveness, and to avoid indirect or unintended harms and ensure the frequent sharing of information. Combat all forms of stigma and discrimination, including those based on race, social contacts, professions as health workers, and those directed towards marginalized groups that prevent them from accessing care. 3. Ensure access to free or affordable screening, testing, and care for the most vulnerable and hard to reach. 4. Remove barriers to people protecting their own health and that of their communities, fear of unemployment, healthcare costs, presence of fake news and misinformation, lack of sanitation, infrastructure, and others. 5. Restrictions to protect public health must be of limited duration, proportionate, necessary, and evidence-based and renewable by court. Put in place exceptions where necessary for vulnerable groups and to ameliorate the consequence of such restrictions. Blanket compulsory bans are rarely effective or necessary. Individuals should not be criminalized for breaching restrictions. 6. Countries must work to support each other to ensure no country is left behind, sharing information, knowledge, resources, and technical expertise. 7. And last, Support and protect healthcare workers. Be kind with each other. Join and support efforts that build trust and amplify solidarity, not sanctions. Adapting evidence-based interventions from the HIV response to reduce stigma and discrimination and integrate them into the global COVID-19 response is critical. Immediate action will reduce the negative impact of COVID-19 on public health and safety and will strengthen our collective ability to control the pandemic by removing critical barriers to seeking care, testing, and adherence to guidelines on physical distancing and use of personal protective equipment, PPE. Many of the following recommendations had been adapted from the report Evidence Update and Guidance for Eliminating HIV-Related Stigma and Discrimination in 6 Settings, and can be readily incorporated into public health responses to address stigma and discriminations related to COVID-19. This guidance to countries is the product of an in-depth research and was reviewed by the Technical Working Group of the Global Partnership for Action to Eliminate All Forms of HIV-Related Stigma and Discrimination. It was published in April 2020 and provides the last evidence on what works to reduce HIV-related stigma and discrimination towards population at risk of being left behind. It provides evidence-based actions for 6 interconnected settings. These are community, workplace, education, healthcare, justice, and emergency and humanitarian settings. All actions recommended have been analyzed at individual, interpersonal, organizational, community, and public policy levels. All of them are right-based. This means available, accessible, acceptable, and good quality, and community-led. For community settings, these include individuals, families, and communities. Let me provide you an example because there is an extensive list of interventions that have been recommended for each of these levels. So, for example, in the case of individual, this means for essential workers, people diagnosed with or recovered from COVID-19, population at risk of being left behind. One intervention is to provide support services for population at risk of being left behind in the COVID-19 response, including access to social protection programs, masks and hand sanitizers, free COVID-19 testing and treatment, mental health services, and counseling. In the organizational level, which includes advocacy organization, networks of people living with HIV, health facilities, community-based organizations, non-governmental organizations, government agencies working on social services and protection, tapping into 30 years of experience of network of people living with HIV, key populations and women's group of implementing stigma reduction programs in the context of HIV, and ensure these groups are involved in COVID-19 response planning. For example, transgender networks in Nepal and Pakistan are providing essential needs packages and outreach in remote areas. For the workplace setting, at the individual level, this means employees. One recommendation is to provide information to staff on confidential mechanisms to report instances of stigma and discrimination, harassment, and bullying related to COVID-19, and to make available mechanisms for seeking redress related to COVID-19 discrimination and articulate them clearly to staff. As one of the recommendations on public policy, which includes local and national duty bearers, public health officials. There is a recommendation of ensuring that sex workers whose work is criminalized in many countries and who have been particularly affected by COVID-19 measures such as stay-at-home orders, curfews, and social distances are included in social protection and financial support programs, for example, cash transfer programs, announced by governments in response to the economic impacts of COVID-19. Recommendations for the healthcare settings. At the individual level, this means people diagnosed with or recovered from COVID-19. A recommendation is to empower populations being left behind with knowledge of their legal rights in the context of COVID-19 and, where appropriate, their obligations under the law and how they can access legal support and redress. An example for the justice settings at the level of organization, that means police, security forces, and prison administrators, the judiciary, civil society organization. It's recommended to provide in-service training for police officers, judiciary members, and prison staff on COVID-19 policies, gender-based and intimate partner violence, key populations, and responsible and supportive policing in the context of the epidemic. Finally, in the emergency and humanitarian settings, at the individual level, these mean populations in emergency settings, our recommendation is to ensure COVID-19 services reach populations in emergency settings to protect their health and well-being, for example, by providing access to social protection programs, masks and hand sanitizers, and free COVID-19 testing and treatment, mental health service and counseling. Another one is to implement programs and services to reduce intersecting stigmas. Example, internalized stigma, stigma related to refugee status, xenophobia, faced by people in conflict and crisis settings and exacerbated by the COVID-19 pandemic. This set of recommendations for each of the 6 settings adapted to COVID-19 will be published shortly in the UNAIDS website. This has been as well reviewed by the Technical Working Group of the Global Partnership for Action and provides useful guidance for countries to address stigma and discrimination and to unpackage them in these 6 settings. The Global Partnership for Action. In December 2017, the Global Partnership was formed to translate political commitments made by member states into action to eliminate HIV-related stigma and discrimination at country level. This global partnership is a technical and political platform that creates an opportunity to harness the combined powers of governments, civil society, bilateral and multilateral donors, academia, and the United Nations to eliminate all forms of HIV-related stigma and discrimination. And as well is taking a close look at the interface between COVID-19, stigma discrimination, and HIV. Thank you very much for giving me this opportunity. Here I leave you with some reference and links to documents that I utilized to develop this presentation. And if you have any questions or you would like additional information, don't hesitate in contacting me. Thank you very much.